Somebody'd like to make them? You got them both? You got them both? Okay. Any discussion? All in favor, please say aye. Those opposed, same sign. Okay, Zim, for you and Amanda, we get these policies because they're joint commission sort of necessary, and they fall under the medical staff, nursing, so they come to this committee. That's why there's the Reverend, how are you, sir? The first one is the Tarrant County Hospital District Board of Managers Resolution of Commitment to Patient Blood Management. Hey there.
Good afternoon. I'm coming this afternoon to request your approval of a resolution for the hospital district to commit to a patient blood management program here at JPS. And this would be going through the Joint Commission as a certification. There's only 7 hospitals right now in the U.S. That have this certification, and there's none in Texas. But what it is it's a commitment from the organization to really look at and study blood conservation, to look at the safety and ordering, administration, transfusion, guidelines, those type things around the administration of blood and blood products. So I'm coming to ask your permission for us to proceed in doing that.
So what is the certification? What is it?
It's in patient blood management.
Blood management. Okay. Any questions for Wanda? Please.
Carter Blood Bank. Absolutely, yes. Mhm. They're actually have a house here in our facility, so.
Okay. Cool. Thank you.
Anything else for Wanda? Somebody may like to make a motion that we approve this.
Second.
Very good. Second from Amanda. Discussion. All in favor, please say aye. Those opposed, same sign.
Thank you. Next, I have just a policy for your review, or it's actually a plan. It's our utilization review and care management plan, and this is a CMS requirement. We've had this plan in place for many years. It's just up for review, and basically it's formatting changes, a little bit of verbiage, and the addition of the line in here to reference the 2 midnight rule. And those are the only
That's
changes.
one of the things I had underlined that folks may not completely understand. Could you explain the 2 midnight rule, please?
I'll do my best. It's very complicated. It sounds easy, but it's not. It's just that once a patient has been in the hospital for more than 2 midnights, then they either need to be discharged or they need to convert to an inpatient status if they've been here under observation status during that time. But once they pass that 2 midnights, then they either need to change status one way or the other.
Okay. Everybody okay with that? Okay. I found one little clerical error for you.
Okay?
At the bottom of page 737, just number 4 should, I think, defines processes, just like the.
Oh, I see that. Okay. Great catch.
There was one I was gonna try and get you before the meeting. But I think the main thing for us, even other approving this, but there are responsibilities for the governing board that are listed here on page 10 out of 37 that we will be coming back to visit. If it's okay. Dorothy? Is there a second? Reverend Ralph Waldo? Second. Discussion? All in favor, please say aye. Those opposed, same sign. Okay. Is that it for you, Wanda?
Thank you, Wanda.
Okay. Rob, I think,
Yes.
does everybody know Dr. Stevens? Okay.
So I think this is also a renewal of a policy, and I'm going to feel a little bit with my drawers down a little bit on this, because actually I wasn't completely aware of this one on the agenda, so my apologies. So please forgive me.
That's okay.
Where does this one start? Do you know which page this starts, Sean? I'm sorry.
It's okay. It's right after utilization management. It's a very short,
Yes, very short.
in my book, it's 21 out of.
21, there we go, I'm sorry. So, this policy of the Kern County Hospital District states that patients and their families or representatives are informed through the proper chain of command about unexpected outcomes of care, including unanticipated outcomes or medical errors. This policy will apply to all district employees and members of the medical staff. So pretty straightforward, but it's basically an intention to say that when something untoward happens to somebody, that we will not conceal this information from the patient, but we'll be upfront and open and let them know about the things that are happening to their to either themselves or to their family members.
And we've had this policy in place.
Yes.
So the only difference is there was a minor correction to this
Yeah.
over time. These policies are going to have word changes, and any change, including a comma, has to come through this governing board for its approval. So this isn't a new policy. This isn't anything that's revolutionary to us. This is just a minor change, and it's got to go through you all to do
Yeah.
that. So that's all there is to this.
And Sam and Amanda, at this committee, we only approve the policies. We don't get into the
Actual
execution
Right.
of how that all works. That's, yeah, the procedure part is highlighted. Okay.
Okay.
Can I make a statement about, even though they have it on our board portal that we can pull up, you can't really pull it up, you have to have a tech number. Okay?
You, tell me again, you have to have a,
And when you click on the procedure, it comes up and it'll ask for the tech password. Policy tech, and it user and their password. So,
I just said, hell,
okay.
I don't, I just thought I'd mention that so y'all could work on that in
Sure.
case I wanted to look at a procedure.
Sean's got it.
I have that issue, and so it's in the reference materials, but it doesn't go to the actual procedure, right? It just goes to the, yeah. Okay. That's all.
Yeah.
Okay, well, we will make sure, and we'll go through policy tech, and I'll ask David to take a look and see what makes it easier for you guys to pull up the procedures in the policy.
Okay.
We can do that. Thank you, Dorothy.
Somebody like to make a motion, we approve it?
Second.
For discussion, all in favor, please say aye. Those opposed, same sign. Kenny's coming up. Kenny Carr.
Everyone. Much like Wanda and Dr. Stevenson, I have a couple of policies that are up for renewal. The first one is the environmental surveillance policy. It's to conduct regular environmental tours of all the areas in the organization and determine whether the current activities are used to manage the environment of care, or EOC, are effective to identify and correct any discernible hazards that may exist to our patients, our families, and visitors. And so this policy, there was a couple of words that were changed, wordsmithing, but overall, nothing substantial has changed.
Okay.
Any questions for Kenny? Entertain a motion to approve.
Second.
Second by Dorothy. You got any discussion? Any questions for Kenny? All in favor, please say aye.
Aye.
Those opposed, same sign. Okay?
Okay.
Next one is in regards to radiation safety. This policy statement is to establish and strictly adhere to the safety procedures and to maintain the records of compliance and control in accordance with the requirements of the Texas Department of State and Health Services Radiation Control Program, and is established standards and procedures for radiation safety to meet all the legal requirements. This policy statement had a couple of wordsmithing and no significant other changes were made.
Questions, comments for Kenny?
Move approval.
Second by Mr. Newman. Yeah.
All right.
Discussion, all in favor, please say aye.
Aye.
Opposed, same sign. All right. Wanda? Thank you, Kenny.
I don't know why we didn't do all your policies when you were up there. But we thought, exercise is always
Get my
good.
last one, I have another one
Yeah,
after
I think
someone
if we
else.
could, we'll just,
Save some.
yeah, bring them all up one time.
I've never thought about that at all. I thought this was some system you had.
Of making them go up and back?
Yeah, exercise, healthy life.
It is. It is all part of our Healthy Life Fitness program.
I looked at that as well, and then I figured out why they have them this way, and that is because they have them grouped by chapter from the Joint Commission, so, rather than person. So I was thinking, okay, why are we up and down? So I figured that out. Okay. My next policy is Patient Care Policy 700, which is our patient education policy. The only change to this was changing the word which to this.
All right.
Okay.
Move approval. That was.
Second by DP. Any discussion?
I have a question on this one. It talks about being culturally competent, but also it doesn't speak about language, and if that information is given within their language. Is there a specific reason, or are y'all using that under culturally appropriate?
I think it would fall under the cultural appropriateness of that, rather than spelling it out specifically.
Okay.
You got it, Anthony?
Yes.
Okay. All in favor, please say aye.
Aye.
Those opposed, same sign. Okay, Wanda, you got the next one.
I do. Next is Patient Care 400, which is our interdisciplinary plan of care policy. The only change in this policy is adding the word written to read the written plan of care may be modified. So it was basically just changing one word.
Okay. All right.
DT, second. Dorothy, second. Discussion, all in favor, please say aye.
Aye.
Those opposed, same sign. Okay. You got-
And,
Wait a second, one.
I'm sorry.
Go ahead with your guardianship policy. You're up.
I'm sorry. The last policy is patient right policy, and it is for guardianship. And the only change to this was under Roman number 1 was to refer to two other policies, which is the informed consent policy and the advanced directive policy. So it's just linking those policies together.
Discussion for,
Move approval.
discussion, all in favor, please say aye.
Aye.
Those opposed, same sign. Hey, you had a question about something.
Well, of course, about the policy, I question, one that said a minute ago about Joint Commission. And so we're doing word corrections or sentence corrections to be in compliance with Joint Commission. But there's a policy that we had some time ago, we had in here, I think. So do we continue to change because they continue to say change?
We
guess
just
I'm-
have to review these policies every so many years, and as we do them, when you read through the standards, we just want to make sure it's as in line with Joint Commission as it can be, so that there's no questions when they come back to that. But we have to review the policy anyway, so it's just making sure that the verbiage is matching what their standard is for that time.
And it comes both ways. We're reviewing those policies, and we go through the chapters that not only CMS, but Joint Commission have, And then Joint Commission will oftentimes send out alerts of changes they have to their own policies, and therefore, we don't want a policy that's outdated with one they change. So it goes both ways, and a lot of this is literally word changes over time.
Oh, okay.
Any questions? Okay, thank you.
Thank you very much.
Thank you.
Last one for Kenny.
Wanda, can you come back up? I'm just kidding.
Well, is there somebody back there that we can,
Somebody who hadn't had exercise today that needs to come up.
Diana, you want to come up? Okay. Safe medication practices.
Yes, sir. So this is a policy statement in regards to reduce the risk of medication errors and adverse events by providing JPS system-wide standards for safe medication practices, medication ordering documentation, and related communications. This policy is just here for review. The changes that were made was that we scratched out John Peter Smith and put JPS, physician to physicians, and updated the references.
Okay. Got DT, is there a second? Second by Dorothy. Discussion for Kenny. All in favor, please say aye.
Aye.
Those opposed, same sign. It passes.
And
Thank you.
we apologize, that's not us wanting to spend more time with you
Yeah,
all,
that's-
although we do, but anytime that, I mean, that's pretty much, and Dorothy, you probably remember that, that's the requirement. If there is any change in any of that wording, it's got to go through the governing body. So whatever we do, we're changing those.
Thank y'all.
Thank you. Performance improvement reports. None of these require action. The first one I have is for Laura. Come right up. You want to bring Rob with you? I mean,
No,
just-
I'm solo today. It's not as fun when you're by yourself. Amanda, I feel bad. You're over there.
I like being in a league of my own. I rise above.
A
I
league of
rise
your
above.
own. Well, good afternoon, everyone. I am here to present the patient experience information and wanted to give a little bit of history on why we measure and collect feedback so that it hopefully starts to answer some of the questions that may be out there for you still on all of the data that we collect and what it actually means. So we actually survey our patients, as you know, through a vendor named NRC Health, and we survey in a variety of ways, which I'll show you in a moment. When we survey our patients, though, it actually leads to increased awareness to our pillars as a whole. And so when our patients come in and they have a great patient experience, what we know is that their anxiety becomes reduced, their trust level in the caregiver increases, and when that happens, we find better quality outcomes. And so tactically, a lot of the work that we do measure against quality outcomes. So for instance, we just recently implemented and really reinforced a tactic on our units, and we found that our pressure ulcers have decreased in those areas. And so there's a direct connect between patient experience and quality, we know. The other part of this is when patients go home and they understand their plan of care or they understand what was said to them in the hospital, they can actually comply with the plan of care. And so it prevents them from returning either to a clinic visit or back to the emergency room or to the urgent care setting. And so we end up finding a blend over into our stewardship pillar as well. The other part of this is that when patients are experiencing really great care, their quality improves, we're doing well financially, our employees end up being more engaged. And so it's really easy to thread the needle through all of our pillars to show that how one impacts the other, impacts the other, impacts the other. And so we measure this, but it's not just about measuring how nice we are, and we've talked about that several times. We actually survey several different areas, and I wanted to just bring this to your attention, although what we show in here is just what's related to our organizational goals, but we actually do survey in all of these areas, and we expect about 200,000 surveys returned this year. So how do we survey? That answer is it depends. Some of our surveys are regulated through CMS, as our HCAP survey is, our inpatient survey. And then some of them we have some latitude with, where we can actually shorten the survey and make it more user-friendly for our patients, so that it's not the lengthy survey that they get if they're on the inpatient side, but a shortened version that still gives us a lot of really good information. But we try to keep the questions as similar as we can, so that we can actually continue to maintain some consistency there. Where possible, we've created those abbreviated surveys. So in our outpatient clinic settings, in our oncology and infusion center, our behavioral health, and our emergency services, we actually use the abbreviated survey. And methodologies that we use are phone and email currently. We have talked with our vendor about the texting feature, and they're not finding a huge response rate with that, surprisingly. And so we're still investigating that. And if we find that that becomes a valid method or a valuable method for surveying, we'll add that to the mix as well. And then currently, we get about 30% of our surveys returned, and industry average is about 18%. Our most recent results for our organizational goals, on the inpatient side, we are hitting target at 5 of our dimensions, improving at the national average rate of improvement. And on the outpatient side, we're hitting 8 of the 10 questions. So we are at target and stretch on our service pillar goals. I included the questions for you as well, along with the dimensions. So on this slide, you'll see the dimensions on the left-hand column, and then the questions that are encompassed within those dimensions. This is for our inpatient survey. And again, the 10 dimensions that are listed on the left-hand column are the dimensions that we are working to improve according to our organizational goal. Here's our outpatient questions, and we've grouped them as well, but there are 10 questions that we ask our patients, and those are listed on the right-hand column. So what do we do with all of this data? We do lots of things with this data, actually. I was sharing with Dr. Weber last week all of the dashboards that we collect and share, and we actually review all of the data. Amanda, you've seen them too. There's lots and lots of data, but we actually do a lot of different actions along with that, the dashboard collection. First of all, we reward and recognize our team members. We do things like WOWs, VIPs, our digital display monitors. We actually include our clinician comments that come through. And so we do 10 a month of the clinician response comments that come back from patients on our TVs throughout the network. We look at all of the trends and opportunities, qualitative and quantitative, and then we work with the leaders in those areas in order to action plan and create tactics that will help them improve their results where needed or celebrate their results where that's warranted. We do prioritize all of our improvement efforts, and so we've grouped those this past year. And because the patient experience team is a smaller team, we have taken on the initiative of training the trainer within that framework. And so we prioritize and trend as much as we can so that we can train our trainers on specific things and not be covering a whole variety of tactics, but rather focus in on 1 or 2 or 3 that will help us get the best results. And then we develop our strategies to make sure that we're consistently caring and providing a compassionate experience for our patients. We tried really hard this year to bring the dimensions alive. The dimensions of care actually cover the house. So there's cleanliness, there's care transitions, there's medications, there's discharge instructions, there's all kinds of things that are incorporated within the dimensions. And so we tried to bring those alive this year, and we're finding quite a bit of success with that. We also round on all of our patients and our employees in different units throughout the hospital, whether it be a unit leader or a clinic leader or an executive that's going out and doing rounds. We spend time with our team members as well as our patients, learning from them. And then we create content for new training programs. So we recently started a certification mastery program in patient experience, and we've completed 2 of those courses now for 3 tracks. one for the outpatient leaders, one for the inpatient leaders, and one for our physicians and APPs. And there are 8 more sessions that we'll be having for that will complete this year, and then our groups will be certified in patient experience as masters. We actually meet and spend time with every employee, every provider, and every leader when they come on board. So whether it be in orientation, whether it be in a learning session, or one-on-one time, we spend a lot of time with them to make sure that they're up to speed on what it is that we need as far as taking care of our patients and what our patients are requesting. And just on the reward and recognition front, last week, Friday, we actually went to the units. We have 9 units within the hospital that are actually meeting goal, which is a huge deal. And we celebrated, we sing a little goofy song and they get tickled. And it's bad, that's all I can say, but they like it and they have fun, and we brought them cookies, and so we were able to celebrate them. We also brought cookies out to the clinics last week for those who are meeting goal as well.
After Laura and her team sings, they give the cookies quickly. Because you want to make sure that you're just not left with the singing part, because
It's bad.
a lot of the folks on staff were not hired for their singing capabilities, and we all proved that.
It's bad. I know. And I had to do it by myself the other day too, and I had to demonstrate it for our language services
Well,
team.
Instead
And
of cookies, could
Say again?
Mr. Early do some cooking?
pies or
Okay.
something, I've heard. So I've heard. There's actually huge requests for that on the floor, so we try to protect him as much as we can. Do you have a question, Dorothy? Sure.
Going back to your outpatient survey question,
Sure.
you know, I see the receptionist and the doctor, but don't we have nursing in that, in the outpatient clinic?
Not in the outpatient clinics, we don't. They're actually grouped with, so most of the outpatient clinic, I should say, is provider-focused, most of the questions, because that tends to be the focus for the patient when they come into the clinic. We do measure some of these other areas, though, like access to care, which we know is not necessarily a satisfier, but can be a dissatisfier, right? And then we measure lots of questions regarding the provider and the experience that is there. That's customary. And then, but there's not actually a specific nursing question set.
I would think you would look at the medical assistants who interact with your patients
Yeah,
very heavily, should be considered. They can either make it a good
Yep.
visit or make it a bad visit for the
Absolutely.
provider. So that would be one that I would look to see if y'all could, when you
Okay.
revise it, add something in there about that.
okay. And your questions, thank you for that. We do get in that open-ended section, we will get feedback regarding good or bad, right? But the beautiful part about this survey is that we actually can maneuver it.
Oh, okay.
And so we'll look into what,
Okay. All right.
what options we have for that. And we have done that in the past, but it's just not on the current survey.
Okay, yeah.
Laura, Ralph?
Yeah, good. In collecting the data, is there a way, or do you have in the form that determines the age and gender of
Yes.
the persons?
Yes, we do. And we can actually segment it out that way. So and that's part of what we do when we're trending and prioritizing. So if we know that, for instance, males who are within the age group of 40 to 60 are a little bit more dissatisfied than females, then we can take a look at what might that be. And in some cases, it's, it depends on the unit, but in some cases, it's a clinical fear or those types of things that with key phrases and key words, we can actually mitigate that before it becomes a problem.
Okay. The reason I ask that is because I was just wondering, when we look at when you get the input back into you, to determine where the most of our response is coming from. Is it your older adults or is it the younger adults, because
Yes.
I noticed when you said the texting that you're still revisiting, it might be the particular age groups who will text back versus the other age groups, so.
Yeah, I don't have that information in front of me, but I can bring it. We do segment it out that way, yes.
Right. No, I didn't ask for it today. I just was saying I had to check that.
Yes, yeah. And we use that to help us as well. Yeah, yeah.
Text, do you use mass text them all at one time or one at a time, you know?
Well, we don't actually use that methodology here. It is a new form that the vendors are trying, but their response rate has not been as high as what they would expect to see, so.
If they text from the same source,
uh,
and
DT stuff to.
sometimes the carrier put a detection on there, and
Oh.
if you text all at one time for more than 1,000 in a short period of time, those
Okay.
are considered spam,
Okay,
and they go right to the unknown senders.
okay,
So when you look at the text, it says one is regular and one's unknown.
I
Unless they
gotcha.
click on that, they will never find the text.
okay,
So they may want to go around, break them down to smaller number of texts anyhow.
okay. I'll share that with them. Thank you. I'll share that with them as well.
But Laura, when is it a question when you are coming into the clinic, how would you like to be notified? Is it by phone, email, or text? I mean, that sometimes helps define how they will answer and what you need to send. Because that's one of the questions that I'm getting now is how would you like the information, phone, text, or email?
Even receipts and all that kind of thing these
Yeah,
days, they're
yeah,
asking you, right? Yeah. So I would love to say that that is fully hardwired and that would happen every time. That is something we are still working on.
Well, maybe
Yeah.
this should be one of those questions, because usually when you fill out your form, when you go to your doctor, that's one of the questions they are now asking, how would you like
Right.
to do that?
Yep.
That would help.
Yep, completely agree.
My final deal on this is for the outpatient survey.
Yeah.
I get a lot of compliments on the eligibility who are in the clinics. And, you know, I don't know if they come up a lot, but they are part of that whole system. So
Yeah.
think about how you can rotate a question asking about them, because
Yeah.
it's very, very positive. And, you know, we get bad news. I'd like to see a few of those.
Yeah, that's a great point. You know, to that point too, about 2 months ago, we actually did a mission moment on that group because they had made such a huge impact on a patient who had written a letter in.
Right.
And so that's a great point. And again, we do have flexibility with this particular survey.
Okay.
So we'll look at all of those.
Okay.
Thank you.
Oh, I have a question.
Sure.
How many touches do they use before they actually get a survey response? Like, is there a number of phone calls, a number
Oh.
of texts? and Is there an average amount?
So they will try 3 attempts, and after that, then they don't try again.
Okay. And you had said that by the end of the year, it'll be 200,000?
About 200,000 we will
And
get.
what percentage of that is a collection of our total population?
Well, it's about 30% response rate on what's sent out, which in the outpatient clinics with this survey, we actually census sample. And then on the inpatient side, it's a random sampling of patients, so.
Yeah. And they
Yeah.
are getting it in a specific language, or is it all coming out in English?
No, it's English and Spanish right now. Mhm. Yep, and then we continue to look at what other options we have.
Thank you.
Yep, my pleasure. Okay. So when we look at specific actions, I mentioned the mastery program already. We have 3 tracks running, and that is the information that you got at the last quality meeting, where there are actually 9 courses, and then putting it all together that relates to the inpatient leadership team, the outpatient leaders, and the physicians or clinicians in those specific areas. We've created dyad and triad partnerships so that our leadership and our physicians or APPs can actually function and work together on different processes, on ways that we can best take care of our patients. So that is underway and going well. We also have HCAPS University, and all of our inpatient leaders have attended that, and that is repeated. This is actually, I think since I've been here, the 3rd time that we've done this. And then the Keywords at Key Times training, all of our PARs in the clinics, we've had over 700 nurses and techs, and then 550 community health employees that have been through that. And then Robert mentioned at the board meeting last week about the Ambassador Development Institute, and we had 300 ambassadors, which are frontline team members who are hand-selected from leadership to attend and become well-versed in different areas. They actually came to our ADI a couple of weeks ago, and our focus was on diversity and inclusion. And so Michelle Green Ford did a presentation, and then we broke into breakouts, and our learning team came in, and we actually worked through real-life scenarios that could come up. And the teams, read the scenarios and then really talked about what the options they had to help take really great care of patients, and we got really great feedback on that. We had, and I'll show you the results of that in just a minute. And then we also work very closely with the diversity and inclusion team on the Serving with Sensitivity, Improving Patient Outcomes sessions that you are aware of from Michelle's presentations, and really looking at who are our patients and how can we best serve them. And we will continue to do that as we move forward. And then we do have a discharge call process that we use for our patients, and we changed the way that we do that recently. And we assigned a discharge call employee to units, and so they actually will call patients from those units and say, you were discharged from my unit yesterday, and ask specific questions around medications, and were they able to get those, or supplies, and were they able to do that? And then they connect back with the leadership on those units to make sure that we are fixing what we need to fix if there's a problem, but celebrating some of those successes. So they ask for recognitions and things like that as well. And those are going well, and in every instance on the units where we began this, every question is moving, and they're moving significantly. That's what I showed you last week, I guess it was, so in some of those units, all of those units that we're doing that. So how effective is our training? Like I said, we do a train-the-trainer model. We do measure these, though, and our outpatients, we've had 445 people come through these sessions already, and the average score was a 4.9 out of 5, and then the quality of the training material was also a 4.9 out of 5. We have 5 classes remaining in community health, and there's about 100 people that are still left to enroll in that. On the inpatient side, we've had over 700 that have completed the training. Again, we had 98% of our input. We measure differently, so we had about 98% of our attendees that rated a 9 or a 10, and then 2% rated it a 7 or an 8. And then the rating of the professional development sessions, again, the same scoring there. And then for our ambassador program, we had 96% of our 300 or so ambassadors that came to that training that rated the day overall very effective. A couple of wins that I wanted to be sure and share with you. We're actually seeing improvement quarter over quarter on nurse communication, on cleanliness on the inpatient unit. Ease of getting an appointment has actually improved on the outpatient side, and there's been a lot of heavy lifting that's gone on with that particular area. And one that I would be remiss if I didn't mention was our MyChart and one-click scheduling that's now in place, and being able to, we're starting being able to schedule on appointments, and that has helped a lot too.
Laura, would you do
Yeah.
me a quick favor for
Sure.
the purposes of Amanda and Zim? Would you just quickly define top box? So when they see
Sure.
percentage of top box, that's a term that
Yep.
they may not be as used to.
Yes, absolutely. Thank you. So top box means, depending on how the question is, what the rating scale is, if it's a 0 to 10 scale, top box would be 9s or 10s. If it is an always, usually, sometimes, or never scale, top box is always. And so what you see in the percentages that are listed here are those patients who rated us top box. Anything else, whether it's a 0 through 8 or a usually, sometimes, or never, you will not see reflected on any of our data. It doesn't count. Thank you. And then we do measure the front desk, and that also is improving as we go through this. I wanted to, on the box on the right-hand side, this is the way that we have measured our inpatient unit for the last several years, with just this one overall rating question, percentile ranking. So what happens is our top box score gets, on the inpatient side, gets correlated to a percentile ranking for every hospital in the country. And so what you see on the right-hand side within that box is our percentile ranking on the inpatient side as compared to every adult acute care hospital in the country. So last year, we hit the 71st percentile. This year, fiscal year to date, we are at the 75th percentile, which puts us in the top quartile of the country.
Can you
Yeah.
go back? On front desk courtesy, respect, outpatient, is that, what is front desk? Where?
Yeah, so it actually, well, the front desk in the clinic.
Or in the clinic?
In the clinic.
Okay.
Mhm. But we also get feedback from our scheduling centers. So we have multiple scheduling centers throughout the network, and we get feedback on those as well as the ease to get an appointment.
Okay.
So you have the two on the left refer to the inpatient side, and the two on the right refer to the outpatient side. Any other questions?
On the ease to get an appointment outpatient, does that include just primary care or specialty also rated in that?
That is we measure for our goal, primary care and specialty
Okay.
care. And then, so and as far as our AIP organizational goal is concerned, we combine those this year. Last year, it was just primary care, but we combined that for the goal this year,
So this year is both of them?
both of them.
Thanks.
Yes.
All right.
Any other comments?
Other comments, questions? Lots of work going on. It takes a village to make this happen, so. But fortunately, we have really compassionate, committed people who want to do right by our patients, and we see that.
Okay.
Thank you all.
Thank you.
Very, very important. For sure. Okay. You're up, Rob.
Put it this way.
Thanks. I wanted to, if we could go on in the slides, I guess, do I have? Yes. So I wanted to go over about 3 items with you. The first is an update on our PSI 90, which is our organizational goal for quality. If you recall from last time, this is our weighted, risk-adjusted measure of 11 serious hospital-acquired conditions. And as you can see, we've really made some phenomenal progress with this goal. So we launched this goal with this fiscal year. We hadn't used it before, so we took about 1 quarter to understand this goal and to come up with strategies around improving it. The first strategy was to make sure that what we were measuring was actually adverse. So as we discussed last time, we needed to get our documentation regarding the care of our patients correct first, to make sure that what we were actually measuring were things that we needed to be measuring. The other thing I should point out about this metric is that it's actually a pulled metric. So what that means is that CMS looks at the things that we document and code in the medical records of our patients, and then on the basis of that, they identify events. Okay, so we don't find events and report them to somebody. They look at the medical records of our patients, and they identify these events by pulling them from the documentation, from the coding that they see when we are submitting bills for the cares of our patients. Now, they actually get to look at everything. They don't just look at the patients who are under Medicare and Medicaid. So this is reflective of all of the patients that we're taking care of at JPS, not just simply the Medicare patients, not specifically those who are covered by CMS programs. So in any case, in the first quarter, we had to spend some time understanding the metric. We then, with the help of our HIM team, Health Information Management team, the CDI team specifically, which is the Clinical Documentation Improvement team within HIM, so lots of acronyms, but anyway, this is an incredibly passionate team, actually, who were also the subject of a mission moment in one of our Leadership Connection meetings recently because of their incredibly enthusiastic work to try to get this documentation and coding correct. And so that's required not only work from them, but also tremendous buy-in from our providers who have to actually document these diagnoses and get them coded correctly. So with that, that is the first effort, and then with some substantial quality improvement efforts, particularly around DVT, which is deep vein thrombosis and pulmonary embolism, we've had some dramatic improvements in the results of PSI 90. So you can see the first 3 months of the fiscal year, our results could have been better. So, the other thing I should point out is that a score of 1 means that the rate of these events is at expected for the severity of the disease that our patients have. So the PSI 90 is essentially reported as a ratio of observed over expected. So 1 means we are at expected. Above 1 means that we're seeing more events than expected, and less than 1 means that we are seeing fewer events than expected. So in the first quarter, we had more events than expected. A lot of these were improperly coded events, so that we were picking up things that were not adverse. And then since that first quarter, as we've made these efforts in clinical documentation and quality improvement as well, we've seen really consistent, strong performance over the last 5, and now the June result will also be strong. So over the last quite a few months now. And the really good news that we have, which is updated from last time, is that we are now better than goal for this particular measure. So we had a target of seeing essentially as many of these events as one would expect, and now we are seeing fewer for the whole year to date, fewer of these events than we would expect. I'll break that down for you just a little bit here. So this is our scorecard for all of these events, and you can see that for the majority of them, we've seen some pretty dramatic improvements. You'll notice things like PSI 11, which is the postoperative respiratory failure rate. We've seen a dramatic improvement there. You can see PE and DVT also beginning to improve, which is great. And you can see postoperative hemorrhage has improved. Our pressure ulcer rate, to Laura's point earlier about the relationship between outstanding patient experience and a quality measure, you can see this actually now reflected in our rate of pressure ulcers in the hospital, and this follows along with some of the work that her team has been spearheading, and everybody else around the organization has been carrying the freight for that very strong effort. So I'm very pleased with this. Obviously, this requires sustained effort to hold on to these gains, and as I'll point out in just a moment, sustaining these gains will have some major positive outcomes for our organization. So the next thing I wanted to talk about with you was our spring leap.
Excuse me,
Yes, please.
before you leave
Yes,
that,
please. Mm-hmm.
what's going on with our septic rate?
So the postoperative sepsis rate. So very good question. So there are very few events baked into this because the rate is supposed to be very low. The sepsis.
Eventually it will happen.
What are they talking about?
So postoperative sepsis is a little bit complicated. If you'll bear with me for a moment, I will describe in a little bit of gory detail exactly what goes into that rate. So to qualify for the postoperative sepsis rate, you have to be admitted to the hospital on a non-emergent basis, and you have to have had something that is called surgery according to DRG, so Diagnostic Related Groups criteria, and you have to have also had sepsis. So you have to have those 3 things. They don't have to be in any particular order, however. I guess the admission has to be first, but the other 2 don't have to be. So for example, one case that was frustrating from the fall was a patient who had been admitted for chemotherapy, developed neutropenic sepsis, had multiple strokes, and then subsequently needed to have a feeding tube placed and a tracheostomy. They had no sepsis following the tracheostomy placement, but that tracheostomy put them over into the surgery diagnostic-related group. So, that ended up being a sepsis, but it was certainly not related to the surgery. So it's a bit of a it's a bit of a quirk of the situation. Why is it so high? Part of that is because of the nature of our patient population, which is a very high acuity patient population. The second thing, and this actually is going to be a little bit interesting to see the impact, but weirdly, bronchoscopy is considered a surgery, although endoscopy is not considered a surgery. This is actually changing in the fall, and there are many, many weird things about some of these measures. So I'm just trying to open the book and explain it a little bit to you. But so in the fall, bronchoscopy, I think in October, bronchoscopy is no longer going to be a surgery according to DRGs, and this is likely to impact teaching hospitals in general more than non-teaching hospitals. This is not immediately obvious as to why this is, but for those of us who have practiced in these sorts of places, you'll understand pretty quickly. In non-teaching hospitals, in the ICU, if a patient needs to be, maybe has mucus plugging or stuff, the attending physicians will typically order some endotracheal suctioning and this sort of thing. In a teaching hospital, frequently they will instead do endotracheal suctioning under direct visualization and do through the endotracheal tube bronchoscopy. This is very frequently done in teaching hospitals, but not in non-teaching hospitals. So I think we're going to see, in quite a few of these sepsises, are precisely in those kinds of patients who were admitted to the ICU for some other reason and ended up getting a bronchoscopy as part of the management of their pneumonia or whatever it is. So I expect that this particular measure will change quite a bit for teaching hospitals going forward, because that bronchoscopy, that essentially endotracheal suctioning under direct visualization, will be removed from the equation for this particular measure. So please forgive me for that extended explanation, but there are some weirdnesses in some of these measures.
Yep. All right, thank you. No, after he went through that and told me, somehow the patient did have sepsis. Somehow they got an infection. Eventually, it was an infection there.
There's no question that these patients got infections, but, as you know, that for example, going back to the patient with neutropenic sepsis in the middle of a chemotherapy treatment, there may well be opportunities for improvement in that, but those things do occur, certainly in that patient population at a higher risk rate than for other patients.
Okay, all right. But when we're looking at that, other hospitals have patients come in and have the same problem, and they're getting chemotherapy. Their rates are not as high, they are identified too, right?
True, there's no question, and I think there are opportunities for improvement in sepsis. I wouldn't deny that. I'm just trying to point out that there are a few weirdnesses in the measure as well. And and the great thing about going back to the whole PSI 90 project in general is that it has given us an opportunity, now that we've tuned the machine, if you will, and that what we're measuring as adverse is more often adverse than it was before. Before, I think there was a lot of issues with documentation and coding, and now we've sort of sorted all that out. So when we look at things that are outlying, like our rate of DVT and PE is still 3 times greater than we would expect, or our postoperative sepsis rate, that has given us opportunities to bring together work groups to evaluate these areas and to come up with action plans to address them. So this is really where we're going with this project now, is that if you go back, you can see the things, as you've noticed, that we've got some things where we're still outlying, and those two, DVT and PE and postoperative sepsis are the 2 areas that clearly stick out there, and those are the areas that we're addressing with work groups and action plans. So I wanted to go over our leapfrog results from the spring. So we had a couple of years of where we had gotten into the B range, and we slipped back to the C range for this spring, which was disappointing, certainly. There were some opportunities for, the one thing I will say is that we missed B by the narrowest margin. If we had been able to take full credit on either one of these measures, barcode administration, medication administration we've been doing for a while, but there were some features that were required in the spring survey that were not possible in the EPIC version that we had running through most of 2018. We had an update at the end of 2018. Now we are able to take full credit for that particular measure. We got 75 points out of 100 for that. Now we can get 100 out of 100. On the other, the SP2, which is culture measurement, feedback, and intervention, we were able to get 100 out of 120 points. We missed the 20 because we didn't have structured feedback and performance evaluation to our executives based on the results of the AHRQ Culture of Patient Safety Survey, which is recommended as a best practice. In advance of the fall survey, we have closed that gap, and so we anticipate that that's going to be better. All that being said, actually, I would anticipate for the fall survey that we will not see an improvement in the score, in the final grade, and the reasons are a couple. Number one, based on the date ranges of the material that's gathered. So actually, let me back up just one second and just explain what goes into Leapfrog. So there are several things. First, our safety practices, which are best practices in terms of organizational effort around a whole variety of different activities, whether it is barcode medication administration or safety practices or whatever. But anyway, there's a whole host of those, and you simply have to demonstrate, you have to be able to document that you're doing those things. So it's just a whole collection of best practices. So, that's, for these surveys, that's really what I consider to be low-hanging fruit. They tell you do this, and you do it. And one of the things that I've been trying to emphasize to my team and to anyone who I end up in front of for any reason is to always ask, why are they asking us to do these things? In other words, to say, as opposed to just trying to check the box, to say, how can we leverage something like going after better Leapfrog performance to actually make us a better organization? So obviously you want to be able to check off all of those boxes. And then the second half of the survey is to look at our results for a whole bunch of different outcomes. Some of them are patient experience, which obviously, as you can see, according to the data Laura presented just a few minutes ago, we're seeing some really strong improvement in experience. 3 measures of experience: communication with doctor, communication with nurse, and communication about medications are all baked into the Leapfrog survey. Results in terms of several hospital-acquired infections, as you can see up here, CAUTI and CLABSI, which are catheter-associated urinary tract infection and central line-associated bloodstream infection, are on the list. Our rates of MRSA and bacteremia sepsis is on the list. Our rates of things like Clostridium difficile infection are on the list. Surgical site infections in colon surgery are on the list. And then, as it turns out, from the PSI 90 data, 6 of the 11 measures from PSI 90 walk straight across to Leapfrog. So the reason that so if we go back to the survey from the spring, we had very strong performance in CAUTI and CLABSI. This isn't surprising because the date range that they were looking at was overlapped with when we had these 2 things on our organizational goals for quality a couple years ago. These other measures we were not performing as well during the period, and again, this is because, number one, the date range that was being looked at for surgical site infection for colon was before we had begun addressing that as an organizational goal, and the PSI 90s were not as good because we hadn't started looking at that either in a systematic way. Going forward, though, with our strong performance in PSI and the fact that we've actually kept our eyes on the colon thing, even though it's it's no longer on the organizational goal. I would anticipate in future surveys after the spring that we may well see some significantly stronger performance in Leapfrog. Any questions about all that? Okay. Coming up as a future thing, as future issues for Leapfrog, there are 3 real main changes that we're looking forward to already for what will probably be important for the spring 2020 Leapfrog survey. There are several new asks from Leapfrog regarding high-risk surgical procedures. One is volume minimums for certain high-risk procedures. These include things like pancreatic resection, esophageal surgery, open aortic surgery, mitral valve repair or replacement. And then they've also asked us to develop appropriateness criteria or adopt appropriateness criteria for each of those kinds of procedures. We have actually gone ahead and done that already, so we are ahead of the curve on that. And those things will be reporting up through a high-risk surgical committee, which has been formed under the leadership of Van Johnson, one of our relatively new trauma and critical care surgeons. Hand hygiene is going to be a big issue going forward as well. We need to be presenting Leapfrog with specific plans around improving hand hygiene, and we need to be coming to you as the board with our results and our plans. And so you can look forward to that as coming attractions as well, probably this fall. Finally, yes, please.
With the PSI and Leapfrog, are our dates off on when they're looking at the information? Is one of them at one period and the other one? Yes. Because you look at the PSI and then I'm looking at Leapfrog, your accidents and cuts and tears.
Oh, yeah.
Yeah, so.
Oh, yeah, there's no question.
Okay.
So there are big differences, in fact. So, and there are differences within the Leapfrog survey as to what hits when. So, for example, for Cowdy and Clabsy and surgical site infections, so all the hospital-acquired infections. For this current survey, it went from mid-2017 to mid-2018. So I'm anticipating for this fall survey, it'll be calendar year 2018 is what they'll be looking at. We don't 100% know, but I'm just charting from past behavior.
I can dig on down in that, but
Right.
PSI dates are more current?
No, so PSI is way delayed in a way, actually.
Okay.
So PSI for this survey actually tracked from October of 2015 to June of 2018. Okay. So one of the reasons they do that for the PSIs is that they're relatively rare events. Mm-hmm. So given that some of these things are rare, if they looked over too short a period of time, you could imagine that there could just be fluctuation based upon when events hit. So they've intentionally given a fairly broad collection time in order to keep that measure relatively smooth, survey to survey for an individual hospital.
Okay. All right, thank you.
Okay, sure, absolutely. But anyway, and for outpatient surgery, again, it's things like looking at appropriateness of patient selection for outpatient surgery, as well as making sure for outpatient surgery centers there are appropriate transfer agreements and that sort of thing. I think that for us will be fairly low-hanging fruit. We're already in pretty good shape in terms of how our ambulatory surgery center is utilized. So I don't think that that's going to be a particular challenge. I think the one challenge out of this group is that because we are a public facility and a lot of our patients can't go elsewhere for surgery, and it's also difficult to become a major referral center for some of these kinds of surgeries. We are obliged frequently to do some sorts of surgeries at relatively low volume. So given that we know that, it just means that we have to perform all the much better in the remainder of the measures to make sure that we get the grade that we really should get. I mean, quite frankly, I think that I would expect a much stronger performance in future surveys, but this fall one, I think we're going to be still in the same range.
No.
Just to put it in perspective for y'all, and I know I've mentioned this before, but the evolution of this organization in regards to Leapfrog and quality checks has come a long way. Mm-hmm. In 2008 and 2009, we had a quality team who had a great opposition to leapfrog and thought the leapfrog information was irrelevant and shouldn't be done. And it was recommended to us as staff, from our own staff, let's just not respond to leapfrog. Never a good idea, but JPS started behind from the very beginning. And they've continuously tried to improve in certain categories. As Rob mentioned, it's not an excuse, but some of our areas in some of our surgeries are smaller percentages, so it is that much more important for us to be higher in the quality at which we provide. So it is a challenge, but we'll be very upfront with you about what that is and where that is and how we compare, because for you as board members, you are going to hear that. Well, I hear you guys got a C, and you should be prepared to understand what that is and why, because you will get questions from the community about that. So I appreciate Rob and his efforts and his team and the quality team overall, not only putting an emphasis behind this, but Rob said the key word. This is not about leapfrog. This is about the best way you can run a healthcare network for outcomes that are positive for our patients. We don't want a low grade. We will obviously celebrate if we get a high grade, but the grade is secondary to what we're performing and what we're doing for our patients. So, Rob, I appreciate your efforts.
Thank you. The final thing I wanted to show you was, and this was a bit of a coming attraction as well for this committee, is that by chart and by best practice, frankly, our chief administrative quality committee should be, by chart, reports to this committee, the Board of Managers Quality Committee. As a coming attraction, you will be receiving the minutes from this committee, but I want to show you what actually goes into this committee in terms of a structure, and I know this is a very busy slide. The two big changes in this structure, because as you can see, there's all kinds of different programs, and for example, some of our key initiative programs, like our stroke program, our sepsis program. I should mention that our stroke program was re-verified in the last couple of weeks with essentially no significant deficiencies at all. I mean, there are a couple of pointers for the future, but was given tremendous commendation. Particularly, the one thing I will mention especially is that the percentage of our patients who receive either thrombolytics or catheter-based interventions for their stroke is off the charts high here. So we are really performing at a very, very high level. But as you can see, there's a lot of different things that report into this. The two I really want to bring out, though, are two new groups that have been formed, and they sit right underneath the PSQG, which is our Quality Council and our Patient Safety Council. So Quality Council is tasked with looking at basically our large quality data, evaluating it, and then developing work groups and action plans around different gaps and vulnerabilities that are identified through larger measures. And for example, this is the group that has taken on the effort of improving our performance in deep vein thrombosis and pulmonary embolism. Their chairman, Dr. Fromm, who's also our chairman of anesthesiology, in addition, has a particular passion around the issue of handoffs and handovers, which is one of the major causes of safety issues, for our patients, and not only here, but in all healthcare organizations, to make sure that communication from one person who's taking care of a patient to another person who's taking care of a patient is structured, meaningful, reproducible, and reliable. And so these are the two major initial efforts that are coming out of that particular group. Our Patient Safety Council is responsible for monitoring all of the outcomes of all of our root cause analyses that are done for not only the sentinel events, which are presented to this body, but also for the serious safety events that are not deemed by Joint Commission to be sentinel, but nonetheless are frequently very, very educational to our organization in terms of understanding our vulnerabilities and beginning to attack them in a meaningful and broad-based way. And so This group is tasked with going through that. The discussions are very robust and frequently lead to further development of action plans that are even more meaningful because we get an even broader base group at the table than we have for our RCAs. The one thing I will say about RCAs in general, since I bring up Patient Safety Council, is that we're now doing them in perhaps an even more robust way than we ever have before. And I'll give a lot of credit to Dr. Hochberg for driving this, but he's elevated the level of attention on all these events to a very high level. We usually have multiple executives in the room for any root cause analysis. We also make sure that there are appropriate physician leaders, not only the physicians involved, but also service line leaders and that sort of thing, which obviously creates the opportunity for a very high-level discussion and very, very meaningful action plans. So it's the role of this particular Patient Safety Council to evaluate those action plans and to make sure they're robust, meaningful, and that as sometimes can happen, the cure is not worse than the disease, so that the solutions that are applied to one particular situation don't cause issues for other departments or groups or other aspects of patient care.
I want to make note, particularly to you, Pastor, that this is the first time you have received an org chart that you didn't ask for it. That's how advanced we are now. We're getting org charts out and you didn't even request it. You may not even like it, but we got one.
Are there any questions about any of this aspect of our quality program?
I think it's pretty damn good.
Thanks, Rob.
coming
Appreciate it
along.
very much.
Thank you.
That's it for the agenda. We have a couple little things in closed session. So with that, we'll temporarily adjourn at what, 2:14?